I just thank the organizers and thank you, Dr. Young, for giving me the opportunity to come and talk this morning. I am impressed that Jennifer just gave such a nice talk on hormonal therapy. I would have no business talking about cervical cancer. I can barely do a pap smear at this point. So I'm always impressed when people can venture out of their field. So proud of you, JY. And I guess there's a P in your name now too. So. My hope for the next half hour is that we'll come out of this with a couple of educational objectives. So first, understanding, as has already been mentioned a couple of times during the meeting, that chemotherapy and radiation pose a threat to gonadal function and future reproduction. Secondly, appreciating the importance of reproductive function to young women and young men facing potentially gonadotoxic therapy. And then I want to really focus on the last point, so providing an awareness of the different options for fertility preservation for these young women, and then some of the resources that are available to help. It always helps to have a case, and so the case, a 36-year-old presents with newly diagnosed invasive ductal carcinoma of the breast. Her cancer treatment will involve surgery, likely followed by chemotherapy and radiation. She's engaged, she's never been pregnant, she and her fiance just haven't gotten to that yet, and she'd like to know how her cancer and the treatment of her cancer is going to affect her future reproductive options. So touching very quickly just on the epidemiology of cancer, this is when I'm in a room with a lot of other people who probably know a lot more about these statistics. But if you look at the SEER data, there's on average 12 million cancer survivors, a little over half of these are women, and there's about a 5% group that are in the reproductive age. So there are a significant number of young individuals who are diagnosed with cancer who are still in the reproductive age group, and this is really who this talk focuses on. What type of cancers are we talking about? So of course breast cancer, but in young women there'll also be melanoma, lymphoma, of course uterine cancers. We don't see many thyroid cancers coming because of the specific ways that cancer is treated. I've seen a patient or two. And then of course also cervical cancer. So these are the women that we see the most. And then because of the good work of people in this room, of course, the advances in cancer treatment has improved survival. And there is not a new, but a continuing to continue to increase importance in improving the quality of the life of survivors and minimizing the morbidity of the cancer therapies. Chief among the concerns of young cancer survivors when they're asked is that their disease or the treatment of their disease is going to affect their future fertility. And there's multiple surveys that ask women with cancer, specifically breast cancer, this is the one that comes up the most. And the majority say that yes, they're concerned about their fertility, and in addition to that, these concerns can influence their treatment decisions. So it is a tough time when you have a new cancer diagnosis, and this is a challenge to talk to them about fertility, but important because what they are learning about that conversation may influence some of the ways that they would like their cancer care to go. ASCO has come out with recommendations. These were mentioned the other day, initially out in 2006 and updated in 2013. And they basically stress the importance of addressing the fertility concerns to these young individuals diagnosed with cancer. And the 2013 recommendations come out with the actual list of the different options for fertility preservation. And this is what I'll focus on for most of this talk, is what is egg and embryo banking, what about ovarian tissue cryopreservation. Dr. Pierce just mentioned the oophoropexy for patients who are gonna get pelvic radiation, Lupron suppression for during chemotherapy, and ovarian tissue banking. So we'll go through some of these different treatments. The flow chart that they have in those recommendations says you assess the patient if they're at risk for infertility as a result of their treatment, talk to them about this risk and see if it's a concern to them. If so, refer to someone like me who then can go through the different options. And for a fertility preservation consult, I'll usually sit down with the patient, make sure I know their age, their diagnosis, what details, if it's known yet, of their cancer treatment plan. And then I usually go through that list of options, starting first with one that isn't on the list. The first is just measurement and observation, and over 50% of patients will elect for that. And it's actually very empowering for them just to say, I say, listen, we can do blood tests, maybe even an ultrasound, we'll measure the ovaries, we'll measure your egg count, we can do this with blood tests. and then I'll see you back in a year. And just the sheer ability to measure and observe and know what's going on, many women find this very satisfying and some amount of control over what's happening to them. So about 50% of patients will opt for this kind of watchful waiting and seeing what happens and have some satisfaction from at least the knowledge and the ability to measure. And then I'll go into the list of the other options, including egg and embryo banking and the Lupron suppression. So why does this happen? So a little bit just about what chemotherapy and radiation does to fertility. So for a female to be fertile, you have to have ovaries or eggs, fallopian tubes, and a uterus, unless someone like me is involved. And for cancer treatments, obviously for the gynecologic cancers, if you remove one of these organs, that's going to pose a significant problem. But the majority of cancer treatments are going to hurt fertility by affecting a woman's ovarian reserve. So it's either the chemotherapy or the radiation, or if you're doing surgery on the ovaries, that's going to decrease the number or the health of the eggs that are remaining. So when I lecture the med students at UAB in their reproduction course, we go over how the ovary is formed and what happens to the eggs. And just a brief review is women are born with the eggs that they are going to have. You have 6 or 7 million halfway through gestation. You're down to 1 to 2 million when you're born. By puberty, you have 300 to 500,000 eggs. And then menopause is essentially when the eggs are gone. And that's an oversimplification, but it works for gives us an operating knowledge for this conversation. So the eggs are going to get used up over time, and that's on autopilot, whether you're pregnant, not pregnant, on birth control pills. The eggs are sort of gradually used up over time, and when you have an insult of either chemotherapy or radiation, you essentially wipe out a significant portion of the eggs that are left. So the impact on chemotherapy on ovarian reserve really depends on a number of things. First is the age of the patient. So if you're starting with a very full gas tank and you have the insult of chemotherapy, you may not get all the way to empty. And so studies looking at breast cancer patients and measuring post-treatment amenorrhea shows that it's very much related to the age of the patient. So someone under 35, they'll go through their standard chemotherapy, and most likely they'll still have a menstrual cycle when they complete their treatment. However, the patient over 40, it's most likely that once they're done with their treatment, they will not get periods and they'll be in menopause. So the age of the patient, because it reflects how many eggs are left or their starting ovarian reserve, is very important. And of course, so is the agent for chemotherapy. Cyclophosphamide in the alkylating agent group, that's the one that we worry about the most. But we pay attention to the exact chemotherapy regimen when we're counseling the patient because the different agents have different risks of injury. And then finally, of course, the duration of treatment. How many cycles are they going to get? What's the dose? Is this their first round? Those things all come into the individualized counseling that the patient gets. What's important is a lot of the studies have been done looking at menstrual cycles as a way of measuring ovarian function and reserve. And that's not a perfect measurement for fertility. It's obviously much easier to ascertain because you can ask the patient. But we know even from normal reproductive aging that you lose fertility late 30s, really early 40s, whereas the average age of menopause is 52. So while it's a marker of ovarian function, the presence of menstrual cycles does not capture fertility issues very well. And there's a group at UCSF that uses the California State Cancer Statistics. They come out with some nice research in this area, and they have a nice publication looking at survivors of breast and lymphoma cancers and see that in the 20, 30-year-old age group, using menstrual cycles grossly underestimates the presence of fertility issues. So while it's easy to talk about periods, and obviously if you're not having a period, that's a major fertility issue, we miss a certain number of patients that are having severely diminished ovarian reserve if we're only using menstrual cycles as a marker for fertility. What about radiation? Dr. Pierce just mentioned this, but you damage the ovary if you expose it to radiation. It depends again on the age of the patient and the dose of the radiation. The ovary is going to get hit if you're doing abdominal, pelvic, or spinal radiation. She talked about how you can do transposition of the ovary. Separate from the ovary, of course, you worry about the uterus. The uterine radiation can result in issues with the function of the endometrium. We actually have a patient right now who had 2 kids, I actually don't know what type of tumor she had, but she required craniospinal radiation, and she was able to bank embryos prior to her cancer treatment. We now have 8 embryos in the freezer, and we've put in 2, one at a time, and her lining just doesn't develop well. There's a stricture within the cavity. This is not likely to be surgically correctable. We're about to do a hysteroscopy to look inside and see, but the radiation has almost certainly done something to the endometrial function. So we can try a couple more transfers into her, and then she would be counseled to consider a gestational carrier. So the other area that's important is the brain. Obviously the hypothalamic pituitary ovarian axis is controlled by the hypothalamus and pituitary. Brain radiation can affect the pituitary gland. Thankfully, this, if the patient ends up with pituitary dysfunction as a result, you can recover that by using the FSH and LH injections that we use standardly for fertility treatment. But we do every once in a while get patients who have survived some treatment that required brain irradiation, and we can usually recover fertility with that by the use of medications. So in terms of options, the New England Journal had a nice review a couple of years ago that went through options for both males and females. For males, I know we're not focusing on that today, but you can bank sperm or testicular tissue. Thankfully, that survives really well in the freezer. And then for females, this is what we'll focus on for the next 10-15 minutes. And talking about egg banking, embryo banking, suppression with the GnRH agonist, and then ovarian transposition, and then also the experimental options of in vitro maturation of eggs and tissue cryopreservation. So embryo banking is the most established and reliable method that we have for fertility preservation. It's essentially the same as what we do to treat infertile couples with IVF, except that instead, so you create embryos, but instead of putting them in, which we do for the couple that's actively trying to get pregnant, we put them in the freezer and save them for future use when it's deemed safe for the patient to try to conceive. This here is a picture of a day 5 embryo. This would be a 4AA, which is our highest graded embryo. You see here the little condensed, this is your inner cell mass. That is the cells that become the baby. And then the rest of this is the sphere of cells, which is called the trophectoderm, and that becomes the placenta. And so if this is an embryo from an under 35-year-old, that embryo, if you put it in, has about a 50% chance of becoming a baby. And so, thankfully, if we are able to get 1 or 2 of these banked away for a patient before she goes through her treatment, if it's safe for her to try to get pregnant later, we stand a pretty good chance by placing these in 1 or 2 at a time. So how do we make that embryo? The patient undergoes ovarian stimulation, so naturally women release 1, maybe 2 eggs each month if you don't do anything to them. By giving fertility shots, you can get multiple eggs to grow, and that's the goal during the 2 weeks of ovarian stimulation, is say, well, instead of 1 egg, let's see if we can get 10 or 15. And that just increases the chances of having options in the future. So the patient does shots for about 2 weeks. And then once you get to optimal growth, you go in under conscious sedation, and with a needle through the vagina, you can poke into the ovaries, drain out the follicles that have grown, and with the follicles, you usually get an egg. Once the eggs are in the lab, if you're doing embryo banking, you then fertilize them with sperm from the partner or from donor sperm, and then by the next day, you know how many of the eggs are fertilized. When you choose to freeze the embryo is a little bit of a conversation with the patient. You can either freeze them right away on day 1, or you can grow them out to day 5 or 6, depending on how much the patient wants to know about the health of the embryos that we have in the freezer. In terms of the pros of embryo banking, so we've performed IVF in this fashion for more than 30 years. Louise Brown is about my age, and so we know that it works. Embryo cryopreservation is a standard technique. We freeze and thaw embryos all the time now in our regular fertility practice, and then success rates are known. So most practices are a member of SART, the Society for Assisted Reproductive Techniques, and so we report the outcomes of our IVF treatments to the CDC. And these are searchable online. Anyone can pull up the SART statistics and look at the national data and look at individual clinic outcomes. And so because you have to wait for the babies to be born, the numbers and rates that we have always fall a couple of years behind what we're doing in treatment today. But you see, for patients going through IVF, transferring embryos now, the success rates for each person with each treatment is about 40%. You see that it starts to go down once the woman gets past age 35, and then the success rates are much, much lower in the woman who's over 40. So while these patients are infertile patients, these are not presumably fertile patients that ended up with cancer who are banking embryos or eggs, you can at least use these data as some sort of guideline of what patients should expect if they choose to go down the road of embryo or egg banking. In terms of frozen embryos, our numbers are not quite as useful for this population, and I'll go through why. The statistics that we have from SART on the success of frozen embryo transfers assume that the best embryo was put in first, and that's not the case if you're doing a freeze-all or embryo banking cycle. So here from the statistics, the live birth rate is somewhere around 30%. In actuality, there's been additional studies that show for freeze-all cycles, if you take the best embryo, you're back up closer to that 40 to 50% success rate. And if you use an egg donor, which is often suggested to be the best cases to use for the otherwise fertile patient with a new cancer diagnosis, success rates can be 50 to 60% for each embryo that goes in. So thankfully, we have these numbers that can help us guide patients into what they can expect to get if they choose to go down the path of embryo banking. What are some of the challenges of treatment? So of course, the timing. If someone is planning to do IVF, we'll often spend a month or at least 2 weeks using some suppression medications to help organize the growth of the eggs. We know that we get the most eggs if you start in the earlier follicular phase. And then it's going to take 2 weeks essentially from the time that someone starts those shots until we have the eggs in the lab. So there's these 14 days that we need to complete a stimulated egg or embryo banking cycle. Cancer patients don't always get diagnosed in their early follicular phase. And thankfully, we have learned to adjust our stimulation protocols so that we can essentially pick someone up wherever they are in their menstrual cycle and just start therapy right then and there. There's other medications that we employ that will still allow us to get essentially the same number of eggs no matter where we start them in their menstrual cycle. And that discovery was 5, 6, 7 years ago of how we can use different medications to help us achieve that. There remains a concern from the patient and then the providers, both on the oncology side and on our side, that could delaying treatment by a week or 10 days or whatever it takes to bank eggs or embryos away, is that going to affect their outcomes? And thankfully that has been shown to not be the case. What does help mainly to relieve anxieties on everyone's part is just to see the patient as early as possible. So it is not uncommon for us to start stimulation, say for a breast cancer patient who's planning neoadjuvant chemo. Let's go ahead and see them, get them started. Maybe they still have some scans to have done. They can get their port placed. Giving us the ability to start as quickly as possible will reduce the time from when their port's in and their treatment regimen has been decided from when they can actually start chemotherapy. And once we've done our retrieval, the patient literally needs no recovery time. They usually feel well the very next day, and treatment can start at that point. Another concern is about estrogen exposure. So when you do these stimulations, your estrogen level goes 10 to 15 times higher than normal. So for estrogen-sensitive tumors, you worry, does this burst of estrogen affect their recurrence rate or survival or the efficacy of their initial treatment? We will standardly use aromatase inhibitors during stimulation if this is the case. Using letrozole or another aromatase inhibitor will decrease the estrogen level during the treatment. Thankfully, doesn't impair the number of eggs we get or the health of the eggs that we get. So it doesn't impair the success of their egg or embryo banking cycle. And then there has been studies, Octay is in New York, he does a lot of studies in this area, and took a cohort of breast cancer patients comparing ones who chose to do IVF using an aromatase inhibitor and compare them to women who had similar cancer characteristics who didn't do any IVF and saw the same recurrence rates at 2 to 3 years out. So this short 2-week burst of estrogen, 1, can be mitigated with an aromatase inhibitor, and 2, doesn't seem to impair the success of the initial treatment. So that's embryo banking. What about egg banking? So embryo banking doesn't work for all women, and actually for most women. Most people come in and because the embryo requires an egg and sperm, many patients don't have a partner, or if they do have a partner, they don't know that they want to fertilize the eggs. You can use donor sperm, but most women, if they're doing this, are interested in preserving options for the future. And if they aren't partner, they want to have the flexibility of being able to fertilize the eggs with the partner that they have in the future. And then also from an ethical or religious standpoint, many patients are very comfortable banking eggs or banking sperm. You can freeze them and then discard them and not think a whole lot about it. But an embryo is different. An embryo is egg and sperm together. The ASRM designates that as a special tissue that has the potential to be a life, but it's not a life. Still, when we are dealing with the disposition of embryos, this is a much more challenging subject, and it deserves to be. And so many patients who are in for a fertility preservation consult are much more uncomfortable creating embryos when they don't know what their future health is going to be. So in many cases, egg banking is a more attractive option, and thankfully is now no longer considered experimental. So what is the change? Our initial attempts to freeze eggs were not that successful. A mature egg is in the middle of meiosis. There's a spindle for the genetic material to separate, and the egg is one of the biggest cells in the body with a lot of water in it. So when you freeze it, literally the ice crystals would mess up the spindle and damage the egg. The other thing that happens when you freeze an egg is the zona pellucida, which is the shell around the egg. It hardens, and that hampers fertilization. So the sperm literally can't bind and fertilize the egg unless you help them. So thankfully, lab techniques have advanced, and there's a method called vitrification, which is a flash freezing of the egg. And we've found that by using vitrification, we do much better with success of freezing and thawing eggs and using them for fertility. The other technique that we use is called ICSI, which we standardly use for IVF, but it's injecting one sperm into the egg, and that gets around the issue with the zona pellucida. So in this picture here, you have a micropipette holding the egg. This is the egg here, the zona is this halo around it, and this microneedle is injecting a sperm, which is right at the tip of the needle. So this is a picture of ICSI. So if someone banks eggs and then we go to use them, you thaw the eggs, you'll require ICSI. So if it's $5,000 or $6,000 to do the work to freeze the eggs, there's going to be $5,000 or $6,000 on the other side when you actually go to use the eggs because of the things that you have to do to get them to fertilize and grow. So it was considered experimental till the ASRM meeting of 2012. I remember the announcement. There was wide applause. Everyone was very happy to have this lifted. And the success rates now can approach conventional IVF. It's very safe. They've done studies looking at babies born from eggs that had been frozen, and there's no increased risk seen of birth defects. And so it's now standardly offered at most practices within the United States. So what about ovarian tissue? So we've talked about if you do the 2 weeks of stimulation to remove eggs, what you can do with those. What about if you just can remove the tissue? And this is attractive because you could do a laparoscopy, remove an ovary, bank that tissue away, and it seems much faster, although it requires a much more involved procedure. The idea is that if you have ovarian tissue, you could then either put it back in at a later date when that's thought to be safe, or use the tissue in the lab to try to grow the eggs and mature the eggs in that tissue out to the point that they could be used in IVF. So the benefits, again, potentially faster, also an option for the pediatric patients who are prepubertal. You can't really do any of the ovarian stimulation if the patient's not in puberty yet. I've stimulated 15 and 16-year-olds, but that's really the limit of what I've done in terms of egg banking. And then there's also the potential that with the whole ovary banked or a significant amount of cortical tissue banked, you may have many more eggs than you could get or 1 and 2 IVF stimulations. So this is just a diagram of what you could do with the tissue. You usually have these cortical strips, and then those would get transplanted back into the native area, or you can transplant it back into the forearm. The experience with this has shown that it can be successful. So with the tissue going either into the pelvis or into the forearm, the graft will survive and it will have hormonal production and the growth of eggs for a short amount of time. So unfortunately, the length of time that this graft survives, though, is not terribly long. So 20% will start to fail at 6 months and even more at 9 months. So there are live births reported from doing ovarian tissue transplantation. What's important to know from these studies is that in those cases, it was almost always the case that one ovary was removed, one ovary was left inside. The patient was deemed an ovarian failure because she was not cycling and had hormonal levels that were in the menopausal range. You transplanted the ovary that had been cryopreserved inside, and then the patient got pregnant. And it's not possible to know where the pregnancy came from. Did it come from the transplanted ovary, or did it come from the quote-unquote non-functioning ovary? And there are women who are diagnosed with premature ovarian failure that end up being pregnant, and it's very humbling when you've had a patient and you said, you're in menopause, none of my treatments will help you, and then she comes in a couple months later pregnant. So we know our tests are not awesome. There was one case in Spain where they took out both ovaries and then put them back in, and she got pregnant. So proof of concept, this can work. but we don't know very well how often and how to cancel these patients. In terms of in vitro maturation, you can't use an egg until it's mature. So if you take an egg out of an ovary, it needs to go through the maturation process before it can be used, because the egg is diploid and you need to lose half of your genetic material before it can fuse with sperm and be usable. So in normal reproduction, this happens when a woman ovulates. And so to be able to have usable eggs in the lab, you have to somehow get to the point where the egg is matured. You can do an egg retrieval without doing the 2 weeks of stimulation. When you do that, you just poke into the smaller follicles and get these immature eggs. And it is possible to take some of these and mature them in the lab, but only 60% of the eggs that you retrieve will be mature, and you get much fewer eggs than if you had used the medications. So this is used in some fertility centers, but it is still considered experimental for sure. Ideally, if you banked tissue, you could use the small immature eggs in that tissue and grow them up in the lab. And this is where there is a lot of hope in our field. Both at Northwestern and out in Oregon, there's groups that are working on 3D bioengineering to try to come up with some structure and the right hormonal cocktail that will allow these immature eggs to develop until a point where they can be usable. With humans, you can sort of get them to grow from a secondary follicle up to the antral stage. In monkeys, you have gotten them all the way up through fertilization and early embryo development. So there is hope here, but still when I'm seeing patients, I strongly counsel them that this is experimental. And while UAB had an IRB to do tissue freezing for the 7 years that I was there, I maybe talked to patients seriously about it 3 times, and all of them elected not to do it because they didn't want to introduce a laparoscopy into their very busy initial cancer diagnosis time. What about Lupron suppression? So with the idea that chemotherapy targets the actively dividing cells, if we can silence the ovary with medication, is that going to quiet it and protect it from chemotherapy? Best studies on this, again, breast cancer population, randomized trials taking women going through chemotherapy and looking to see that if you use Lupron in addition to your chemotherapy, is that going to help protect the ovary? And the results of the studies are mixed. So some of the randomized controlled trials show no benefit, and others do show that the risk of menopause or lack of menstrual cycles afterwards are reduced in the women who've been on Lupron. So it's still uncertain exactly who, if there's a benefit from this, or who would benefit from this. For me, this is a really happy medium road for the patient who wants something more than just monitoring, but doesn't have the wherewithal or finances or ability to proceed with egg or embryo banking. There is some benefit that they feel from doing something, and so they're strongly counseled, I don't know that this is going to help you, but this shouldn't harm you, and if you're willing to get a shot every month while you're getting your chemotherapy, the side effects of this are minimal, and many patients will elect to do this as sort of a happy middle ground. Satisfies the desire to be doing something, and it may potentially be beneficial. And then finally, the ovarian transposition, Dr. Pierce mentioned this, moving the ovaries, usually lateral. You have to sacrifice a fallopian tube to do this, but it allows them to get out of the radiation field. And I've definitely done retrievals in patients who have had treatment for cervical cancer. It's interesting because every once in a while we do the retrieval abdominally because the ovary's up over here now, so the vagina is not the best way to get at it, but you can poke a needle through the abdominal wall and harvest the eggs that way. It helps the radiation oncologist, you tell them where you move the ovary to, so it's poor form to move the ovary and not tag it. So you usually put a clip on either pole of the ovary so they know where you put it, and then that is the most helpful to them. So in terms of challenges, when we had the genetic counseling part of the meeting at lunch yesterday, it made me think of this part of my talk. So why embark down a path if you can't see it through? And so that's an important thing to be thinking about is it going to be safe for this patient to be pregnant later? And you often don't know, but it's important to think about why are we banking away eggs or embryos if these are not going to be able to be used? And so is it safe to become pregnant after cancer? And in many cases it is. Again, studying the breast cancer population and looking at breast cancer survivors, the studies that look at this show a reduced risk of death in those who get pregnant after their cancer treatment. Now, despite these studies doing everything they can to control for confounders and match with the appropriate control group, there is still the concern that there's this healthy mother effect, that there are some unmeasured confounders that are selecting women who have a better prognosis for survival and allowing those to go ahead and get pregnant. But still, when I look at this data, I say, these are reassuring. It's going to need to be individualized, and I typically am not seeing someone back to use their eggs or embryos until they've had a 2 to 3 year cancer-free survival interval from their treatment. In terms of other challenges, of course, awareness and referrals. There's been multiple surveys done of the oncologist population about, are they aware of the guidelines? If so, does this affect their counseling? And there definitely is still room for penetration there for adopting the guidelines and referring to fertility preservation specialists. In terms of different tools for the people sitting in this room, one that I love talking about is Fertile Hope. So Fertile Hope is a success story because Lindsay Norbeck is the founder of Fertile Hope. She herself is a survivor of ENT cancer and started this nonprofit because she was disappointed to see there was not resources and things available to help for fertility preservation. She then became a mother and had to hand off her organization to Livestrong because one, its popularity had grown and she was a busy mom. So within the Fertile Hope and now the Livestrong resources, you can have a risk calculator to help the providers know what the risk of fertility issues are going to be. And then importantly, there's also financial assistance through the Sharing Hope program. So I have patients apply for this routinely to get a discount on their fertility medications because the cost of treatment is a major barrier for patients who want to do egg or embryo banking. So this is just a screenshot of the Livestrong resources. This is helpful for patients because they can't take in everything you're talking to them at the consult. And then the Oncofertility Consortium has a very nice webpage as well. It's good for patients. It provides information about the different treatment options we just discussed. And then also providers, it has a similar risk stratification to let you know kind of who's high risk, who's medium risk, and it allows you to help counsel the patients when you know the specifics of their treatment. So in summary, fertility preservation options exist for the reproductive age cancer patients who want future childbearing. Embryo banking is by far the most established method. Thankfully, egg banking is almost coming up second there, no longer experimental. The determination of what you do and what someone needs absolutely is an individualized assessment. And given the importance of reproduction, counseling regarding this is an essential part of care. So thank you very much.